today the topic is this carcinoma tongue case presentation. Will be presented by Dr. Srujali Roy from the Samajiguda, Yashoda Cancer Hospital, and will be moderated by Dr. Sanjukta Padhi, professor from Acharya Harihar Regional Cancer Center, Kotak. And around 8 o'clock, again, we will start the biostatistics OSCE, which will be moderated by Dr. Ajitesh Avinas, and the questions will be answered by Dr. Ankita from Apollo Kolkata. So welcome you all. We request you don't um, uh, do not speak in the background, and whatever you are feeling the answering the questions, just write in the chat box. It will be appreciated. And what are your questions in your mind, you can write in the chat box. At last we will answer your questions. Thank you very much. Over to you, Dr. Sujali.
Hello. Yes, good evening, sir. Good evening, ma'am.
You start your presentation. Okay.
Okay. Okay, sir.
Okay.
So should I start now?
No problem. Yes, yes.
Okay, sir. Good evening, ma'am. Good evening, sir. I'm Dr. Surjali from Yashoda Samajiguda. Today I'll be presenting a case on CA tongue. So my patient is a 58-year-old gentleman from Adilabad who is a driver by profession and Hindu by religion, and he belongs to the lower middle class socioeconomic strata according to the modified Kupuswamy scale. He presented to the OPD with chief complaints of ulcer over the tongue for the last 1 year and difficulty in eating food and spice intolerance for the last 4 months, associated with recent onset difficulty in tongue movement for the last 15 days. The patient was apparently well 1 year back when he noticed some whitish patches over the left lateral border of the tongue, which was insidious in onset and painless in nature and was approximately 2 into 3 centimeter in size to begin with. It was not associated with any discharge or any foul smell or bleeding at that time, and it could not be scraped off with finger or brush. He had consulted a local doctor that time, where it was treated conservatively as a case of oral thrush. Over the course of time, the patch had gradually enlarged in size to attain the current size, coming to involve the both sides of the tongue. It was, however, still not associated with any foul smell or any discharge or bleeding, but there was occasional pain which was intermittent in onset, burning in nature, not radiating to the ear or throat, aggravating with intake of food and relieved by intake of oral NSAIDs. The patient had difficulty in eating food over the last 4 months, especially solid and spicy food associated with some pooling of saliva. Patient also noticed that he had difficulty in touching his tongue to his palate and also felt some restriction while trying to protrude his tongue for the last 15 days, for which he visited us in the OPD. The patient does not complain of any ear pain, any throat pain, pain in the cheek or eye or over the face, any complaints of blocked nose or loss of sensation, deviation of mouth, or any watering from the eye. The patient also does not give any history of any difficulty in phonation or any hoarseness in voice. He does not have any history of fever, night sweats, weight loss, or loss of appetite. He also does not have any history of recurrent infections or cough or chest pain, hemoptysis, or any pain, abdomen, nausea, vomiting, or any swelling in the abdomen. He does not give any history of headache, confusion, or any episode of convulsions, and does not have any complaints of bony pain anywhere in the body or any pathological fractures. The patient does not give any history of any major illness requiring hospital admission or any past major surgical intervention. He also does not have any dental procedures done in the recent past and does not have any previous malignancy in the head neck region requiring radiation. He does not have any self or family history of tuberculosis. Patient is a known diabetic but is controlled on medication. He has no other comorbidities. Bladder and bowel functions are normal and within voluntary control. Sleep and appetite are normal. Patient denies any history of high-risk sexual behavior. He is a former beedi smoker for the past 20 years, but he quit 2 years back. He also has a habit of quit chewing for the last 20 years, which he has stopped only 15 days back. He denies any other addictions. He usually takes a mixed diet. However, he is taking semi-solid or puree form of food and bland diet for the last few months. The patient does not have any family history of malignancy, and he is unaware of any genetic syndromes running in the family. Now I'll come to the examination of the patient. So on a general examination of the patient, he was examined in sitting position in a well-lit room. His ECOG performance status was 0. He was well nourished and moderately built. His weight was 56 kgs and height was 167 centimeter. He does not have any pallor, cyanosis, clubbing, edema, or icterus, or any gross lymphadenopathy anywhere in the body. Baseline swallowing and speech functions were normal. WHO pain score was 3 on 10. He does not have any dehydration and his vitals were stable. On Now moving on to local examination, the procedure of the entire examination was explained to the patient and verbal consent was taken. He was then examined in sitting position in a well-lit room. On inspection, his facial symmetry was intact. There was no scar, ulcer, or sinus seen anywhere over the face. His lips were unremarkable, and muscles of mastication and facial expressions appeared normal. On asking to open his mouth, restricted mouth opening, restricted mouth opening was noted. Gingivobuccal sulcus and gingivolabial sulcus appeared normal with no ulceration seen. The patient is partially edentulous in the upper and lower incisorial region with sharp canines when noted. And there was extensive tobacco staining of the molars and premolars. There was no caries tooth that was seen. The retromolar trigone appeared uninvolved and buccal mucosa looked healthy. On inspection of the tongue, there was a pale whitish ulcerative lesion majorly on the left lateral border, starting approximately 1 millimeter from the tip and extending posteriorly up to the circumvallate papillae. Irregular margins, the lesion had irregular margins and were extending on the dorsum of the tongue approximately 1 centimeter short of the midline, also extending to the undersurface of the tongue. Another lesion was seen in the right lateral border of the tongue, approximately 2 millimeter from the tip, not extending to the posterior part of the tongue, with apparently healthy looking tongue in between the two lesions. Tongue protrusion and tongue movements were restricted. There was no wasting of the tongue. Tongue depressor was used to visualize the posterior extent of the lesion. The base of the tongue appeared uninvolved. The lesion on the left side was approximately 5 into 3 centimeter on inspection, and the right side lesion was approximately 3 into 1.5 centimeters on inspection. The uvula was normal and centralized. The patient was asked to phonate, and the palatal arches appeared normal. Anterior tonsillar pillars looked healthy. Examination under anesthesia was not done, and Hopkins examination and indirect laryngoscopy was also not done. On examination of the neck, there was no visible fullness that could be appreciated in the neck or the supraclavicular fossa. On palpation, findings were confirmed. Sensations over the face was intact and there was no muscle wasting. There was no loose tooth palpable. A lubricated gloved finger was inserted inside the mouth, and all subsets of the oral cavity was examined with special attention to the tongue. A shallow ulcero-infiltrative lesion in the left lateral border of the tongue was palpable, which had everted edges, irregular margin, firm and indurated base. The induration was crossing midline and involving almost the entire tongue. It was painful and pressing, and there was no bleeding or any serous or sanguineous discharge or any necrotic debris. A lesion measured approximately 7.5 into 5 centimeter. Undersurface of the tongue and floor of the mouth were also involved. Base of the tongue was free. The neck was examined from behind the patient, and there was a palpable level 1A lymph node, which was not visible on inspection. It was approximately 1.5 into 1.5 centimeter in size. The surface was smooth and it was firm in consistency with regular margins, not adherent to overlying skin or underlying muscle. Local temperature was not elevated. There was no other significant lymphadenopathy in any other cervical stations that could be appreciated. Bilateral supraclavicular fossa was examined and there was no palpable lymphadenopathy. So, on systemic examination, there was all the systems, the CNS, respiratory system, CVS, per abdomen, and musculoskeletal systems were examined one by one, and everything was within normal limits. Uh, this is the so to summarize my case. My patient is a 58-year-old gentleman who presented with complaints of long-stand ulceration over the tongue, which was insidious in onset, gradually progressing, initially painless, but recently associated with intermittent local pain and odynophagia. There is no complaint of significant weight loss or any constitutional symptoms. However, the risk factor profile of the patient and my examination findings of a large ulcero-infiltrative lesion epicentered in the left lateral border of the tongue with induration involving almost the entire tongue along with presence of enlarged cervical level 1A lymph node points towards a most probable diagnosis of locally advanced malignant lesion of the tongue, clinically CT4N1M0.
Sujali, Dr. Sujali.
Yes, ma'am.
Okay. So when you are examining, coming to your history part, go back to your history.
Yes, ma'am.
Okay. Go next slide. So usually we don't write as negative history. In the history of
Okay.
present illness, so we tell about the insidious onset of the disease and what we have examined and what the pertinent negative findings. And for the ulcer of tongue, what is your pertinent negative findings that you have to tell?
Okay, ma'am. So the ulcer in the tongue was not associated with any bleeding, any discharge, or any proliferative growth,
Okay.
and it was initially not painless, but it was tender to touch.
Okay, you just tell that there is pain on touch, not pressing. You
Okay.
have written that pain in pressing.
Yes, ma'am.
Okay, so there
Okay.
is no pain and there is no bleeding. And is there discharge from the ulcer?
No discharge, ma'am. No discharge,
So
no
you have to
bleeding.
tell that. And what else you have to tell? Describe your ulcer.
Ma'am, the ulcer was looking pale on inspection and it had everted edges and the margins were irregular. There was no necrotic debris on the floor and on palpation, the base was indurated.
Okay. So in inspection, you told there are two swellings. One is left and one in right.
Yes, ma'am.
So the your inspection findings, going to inspection, prior to that you have to tell that there is trismus. Is there trismus? Difficulty
Yes,
in
ma'am.
opening?
There is difficulty in opening of the mouth. There is
Okay.
grade 1 trismus, ma'am.
So describe grade one.
Ma'am, grade 1 trismus is described as the interincisorial distance less than 35 millimeter, but not less than 25 millimeter.
That means 25 to 35 mouth opening.
Yes, ma'am.
What about grade 2?
Ma'am, grade 2 is 25 to 15, 25 to 20
15
millimeter
to
mouth open.
25, 15 to
15 to,
25, and less than 50 means grade 3. So patient is grade 1.
yes, ma'am.
Okay. Then you have inspected the lip and the
Yes, ma'am.
mucosa and the gum and the tongue part. Okay.
Yes, ma'am.
So you have to confirm your palpatory findings, inspection findings on palpation. So
Yes.
is there two swellings or there is only single swelling? on
Ma'am, ma'am, on inspection, it appeared to be two different lesions because there was apparently normal-looking tongue in between the two lesions. But on palpation, the induration was extending beyond the visible lesion. So on palpation, it feels like it is a single lesion involving almost the entire tongue, ma'am.
entire tongue, and there is a ulcer of size.
Ma'am, the ulcer on the left side is approximately 7 into approximately 7 into 4.5 centimeter, ma'am, on palpation, and right side it is approximately 3 into 1.5 centimeter.
And it is not extended to your base of tongue.
No, ma'am, base of tongue is free.
Free. Okay. And what about your anterior tonsillar pillar and vocal mucosa?
Ma'am, the anterior tonsillar pillar are also normal. The ulcer is not extending up to the anterior tonsillar pillar, and bilateral buccal mucosa are also normal, ma'am.
Have you mentioned about the movement of the tongues?
Yes, ma'am. The tongue movements are restricted. The protrusion and the elevation of the tongue, these movements are restricted. However, the patient can move the tongue side to side.
So you see, he can protrude but not fully. You mean to
Uh,
say that?
yes, ma'am. A little bit he can protrude, but he cannot protrude it outside the oral cavity
Is there any
completely.
ankylosing?
Ma'am, floor of the mouth is involved, so I'm suspecting ankyloglossia is there, ma'am.
Okay. Go to your neck node palpation. How did you palpate?
Ma'am, actually,
You stood by the side of the patient, right side or left side or back or front?
ma'am, I'm standing behind the patient, and
Okay.
ma'am, actually, I did the neck node palpation by standing behind the patient, and I asked the patient to flex the neck. And starting from level 1A, the submental lymph nodes, then I asked the patient to bend the neck towards the side that I was palpating, and I palpated the submandibular region, the level 1B, and the upper jugular, middle, and lower jugular along the internal jugular veins. And as for the supraclavicular lymph nodes, I asked the patient to shrug, and then I palpated in the supraclavicular fossa, ma'am.
So level 1 lymph nodes palpated from behind or from front?
Uh,
Level 1 is 2, no? Level 1A and 1B.
yes, ma'am. From behind only, ma'am.
You have palpated from behind.
Yes, ma'am.
The submental also.
Yes, ma'am.
Okay. The level 1 can palpate from the front. You have to
Okay, ma'am.
palpate the submental first, then you have to palpate the submandibular. So which
Okay,
side
ma'am.
neck node you have palpated?
Ma'am, I palpated the neck nodes on both the sides, one
Mm-hmm.
by one.
Mm-hmm.
There was level 1A palpable lymphadenopathy was there, ma'am.
Which side? You have to mention the side. You have to mention the side also, and left side or right side.
Um, um,
Neck node. Left
um,
side
um,
1B is palpable or right side 1B?
um, Ma'am, 1B was not palpable, ma'am. 1A was
1A
palpable.
is palpable. Okay, you didn't palpate, you didn't fill 1B.
No, ma'am. 1B, there
So
was
you
no
have only
lymphadenopathy.
felt the submental node, no?
Yes, yes, ma'am. Submental
Okay.
node.
So describe any lymph node. How you will describe? If there is any lymph node in level 2 area, then how you would have described that? Describe this.
Ma'am, when the lymph node is palpated, first I will check the local temperature on the surface of the skin overlying the lymph node, whether it is elevated or not. Then going to deep palpation, I'll check the surface of the node, whether it is smooth or nodular, or and the consistency of the lymph node, whether it is firm, rubbery, or duffy feeling, and the margins of the lymph node, whether it is regular or irregular, and whether it is adherent to the underlying structures like the sternocleidomastoid muscle or the vessels, or whether it is adherent to the overlying skin by trying to pinch the skin. These are to ascertain whether there is an extranodal extension or not. And I will also measure the size of the lymph node. Um, and I'll mention the site of the lymph node, which cervical station the lymph node is located.
Fine. When you are asked to describe the lymph node, first you tell that whether that the skin is okay, the skin over the, you check for the inflammatory findings. Then you have to tell what is the site. You
Okay, ma'am.
first tell the site, then size, then the size, then the consistency. So coming to the consistency, what are the three types of consistency you can feel in a lymph node?
Ma'am, it can be either soft cystic or it can be firm, solid firm consistency, which can either be rubbery or duffy feeling, or it can be stony hard, ma'am.
Stony hard. So then after the consistency, what you have to find out? Whether
Ma'am,
that is oval in shape or rounded shape. Okay.
yes, ma'am. Okay, ma'am.
So you have to differentiate from the consistency and the shape, whether something is coming to your mind, whether that is infective or that is inflammatory or that is malignant.
Okay, ma'am.
Okay. So when it is more rounded shape and is hard in consistency. So how you can feel the consistency? Can you describe how you can know that the node is hard to feel, and what is firm and what is soft?
Ma'am, if the lymph node on palpation feels like similar consistency like my lips, I will call it soft. If it feels like the consistency that of the nasal cartilage, then I will call it firm. And if the feel is like similar to that of the feel of the chin or the mentum, then I will call it hard, ma'am.
Okay. And the other way, when you feel your lobule of the ear, it is soft. Okay. And
Yes,
tip
ma'am.
of the nose is firm,
Yes, ma'am.
and the glabella of the forehead in between
Hmm.
your two eyebrows, that
Yes,
is
ma'am.
your heart. Hello. Am I
Hello. Yes,
audible?
ma'am.
Yeah.
Yes,
Yes,
ma'am.
ma'am.
Continue.
Okay. So when it is firm, the suspicion may go into some other primaries. Like if form, you get in lymphoma, but when it is hard, your suspicion are going into malignant cell. Okay.
Okay, ma'am.
So the feeling of the node is very important, very pertinent for us. Then what you are going to find out in a lymph node examination?
Um, Ma'am,
Height is done, size is done, the feeling consistency is done, this more globular shape is done. Then what else you have to find out?
ma'am, any fixity to the underlying structures or the overlying skin, ma'am?
Overlying skin. Okay. And or the mobility is mobile or it is fixed. When it is fixed, whether it is fixed to the underlying structure or overlying skin. So
Okay,
how
ma'am.
you will know the node is fixed to the underlying structure?
Ma'am, I will try to move the node along the fibers of the sternocleidomastoid and also perpendicular to the fibers of the sternocleidomastoid. And if the node is not moving, not mobile, then I'll call it fixed to the underlying structures.
See, when you are moving something, some long or some node along the line of the fibers, then you are making taut, the
Yes, ma'am.
muscle taut, then you feel, is there any difference? Then you can only tell that it is fixed.
Yes, ma'am.
Okay. And mobile, you can freely move it. From the one side you press, that will go to the other side. So, fixity is, now you can know the fixity. Then how you can feel the fixity to the skin?
Ma'am, I will try to pinch the skin overlying the node. If the skin is pinchable, then it is not fixed to the skin. And also on inspection, if it is fixed to the skin will appear shiny. So, if these two things are not there, I can say that the node is not fixed to the skin, ma'am.
Okay. If the skin is not pinchable and you feel that it is fixed to the skin, what clinical information it gives to us?
Um, Ma'am, a clinical assessment of fixity to the skin will help me to know that extranodal extension is present uh,
Yeah. It
for that
gives
month.
impression that there might be ENE, which can be confirmed later on the imaging part. Okay,
Yes, ma'am.
fine. Then you tell me the lymph node stations one by one.
Ma'am,
Level
current,
1 is palpated from the front, and
yes,
rest
ma'am.
other stations are palpated from behind.
Okay, ma'am.
Okay. As ideally, when you palpate one side, flex that neck to the same side, and likewise, if you palpate right side, flex the neck to right, and fix the head from one hand of yours. Then you palpate the nodes, and
Okay, ma'am.
for the supraclav nodes, you palpate bilaterally, both the
Yes,
sides.
ma'am.
Okay.
Okay. Yes, ma'am.
So, tell
Ma'am,
me the
can
location of the lymph nodes, means how you palpate the lymph nodal stations.
Ma'am, there are 10 lymph nodal stations.
Okay.
Level 1A, I will see in the level 1 is the submental lymph nodes, which I will palpate between the two bellies of the digastric muscle, just posterior to the mentum. Level 1B is the submandibular lymph nodes, which I will palpate in the submandibular fossa. Uh, Level 2 is the upper jugular lymph node, which will be palpated along the anterior border of the sternocleidomastoid uh, in the superior part of the neck, uh, above the hyoid bone. Level 3 is the middle jugular lymph nodes, which is located between the level of hyoid and cricoid cartilages and along the anterior border of the sternocleidomastoid muscle, ma'am. And
Okay.
level 4A is palpated below the level of the cricoid, 2 centimeter above the suprasternal notch along the anterior border of the sternocleidomastoid muscle. And level 4B is the medial supraclavicular lymph nodes, which is located uh, from 2 centimeter above the suprasternal notch till the suprasternal notch. And level 5A and 5B are the posterior triangle lymph nodes, ma'am, which are located posterior to the sternocleidomastoid muscle. And 5C is the lateral supraclavicular lymph nodes, ma'am. And level 6 is the anterior group of lymph nodes. Um, Level 7 is divided into 7A and 7B. 7A is the retropharyngeal lymph node and 7B is the retrostyloid lymph nodes. These cannot be palpated clinically, and
But you can
level
imaging.
level on
The,
imaging we can see this, ma'am.
okay.
And level 9 is the buccofacial group of lymph nodes.
Level
And
7 you told, no? Level 7 you have told. Level 8.
um, level 8 level 8 I forgot, ma'am.
Okay.
Ma'am, level 9 is the buccofacial group of lymph nodes, and level 10 is again divided into 10A and 10B, which is the suboccipital, the posterior auricular, and the suboccipital group of lymph nodes, ma'am.
Okay. So level 8 is that a parotid group of lymph node?
Yes, ma'am. I
Okay, sometimes you will be asked by the examiner to draw the neck node part. Can you draw it? Can you? I think you know that how to draw the lymph node levels.
Yes, ma'am.
Okay, so you will be asked in the exam to do some. The examiner might ask you to draw the. So you must practice it while examining. Okay.
Okay, ma'am.
So your provisional diagnosis with this, your provisional diagnosis is
Ma'am, my provisional diagnosis is a malignant lesion of the locally advanced malignant lesion of the tongue. Most likely for this location and given the clinical features, it is likely a squamous cell carcinoma. But I have to confirm
Don't
my
tell like that. You can could tell that it could be a malignant ulcer of tongue with
malignant
nectar.
ulcer.
So, what can be the provisional diagnosis? Always provisional. So you have to confirm it. Okay.
Yes,
So
ma'am.
I will ask you that what can be your differential diagnosis? What other diagnosis it could be?
Ma'am, my
See, tongue ulcers are not always malignant. So,
yes,
what
ma'am.
are the benign ulcers that can mimic malignant ulcers?
Ma'am,
Tell me.
my differential diagnosis will be either a traumatic ulcer of the tongue, as the patient is having sharp tooth, history of sharp tooth, and also it can be a tubercular ulcer of the tongue.
So,
Also,
you tell one like a tubercular ulcer and you describe how it differs from your finding. So, that is excluded. Tuberculosis is excluded. You have to exclude syphilitic ulcers. You have to exclude
yes, ma'am.
traumatic ulcers. Likewise, huh? You tell
Yes,
it
ma'am.
would be tubercular ulcer, but in tuberculosis, we find this undermine age,
Yes,
these
ma'am.
things. Oh, you tell that. So
Undermined
we
edges
cover everything. Yeah.
and patient will also have history of patient this patient does not have any history of fever or night sweats, any constitutional symptoms associated with tuberculosis, and also patient does not have any history of cough or hemoptysis which would suggest a pulmonary tubercular foci. So I can, and the lesion does not have undermined edges, instead it has everted edges, so I can rule out tubercular ulcer, ma'am.
Okay. How to rule out syphilitic ulcer and this? Can it be aphthous ulcer?
Ma'am, it can be aphthous ulcer, but aphthous ulcer will be more painful, and it will be more of a erythematous appearance. This patient's ulcer looks more pale, not erythematous. So,
Okay. So
I,
aphthous ulcer are always small, and the center area is red and surrounded by a
yes, ma'am.
yellow rim. Okay.
Okay,
And it
ma'am.
is very painful. So you have ruled out aphthous ulcer. Is it a traumatic ulcer?
Mm, ma'am, traumatic ulcer can be a differential, but in this case, given the patient's long-standing history, chronic history,
Mhm.
and it is unlikely to be a traumatic ulcer, ma'am.
So can it be a dental ulcer like sharp tooth? With that is also chronic, no? Non-healing
I
ulcer, chronic non-healing ulcer. What
yes,
is
ma'am.
4S? 4S that can lead to an ulcer tongue.
4S is smoking, sharp tooth.
Mm-hmm.
Uh, mm, I I don't know the other two, ma'am.
Okay. Smoking is syphilis and, spicy foods or an irritation.
Oh, okay, ma'am.
Smoking also.
Okay, ma'am.
So you have ruled out tuberculosis, syphilitic, and traumatic. So can you emphasize on what are the causes? What can be the cause in this case?
Ma'am, in this case, the patient is a chronic smoker, and he also has a history of sharp tooth, which can cause frequent friction over the lateral edges of the tongue, thereby causing any pre-malignant lesion, which, if neglected, can turn into malignancy. And also, long-term history of patient also has a history of quid chewing, which is again associated with increased risk of malignancy. So these factors suggest that this can be a malignant ulcer, ma'am.
Okay. So how are you going to confirm your diagnosis?
Ma'am, to confirm my diagnosis, I would like to take a biopsy from the edge of the lesion in the left lateral border of the tongue, and I would also like to get an USG guided FNSC from the level 1A lymph node, ma'am.
Coming to the biopsy part first, what type of biopsy you know that can be done in head and neck cancer?
Ma'am, first I can do a punch biopsy, ma'am.
Mm-hmm. Punch
From
biopsy, what are the suitable cases for punch biopsy?
punch biopsy, more suitable cases are if it is an ulcer or proliferative lesion with a big proliferative mass.
Mm-hmm. But in your case, that is not a proliferative
Yes,
mass,
ma'am.
that is
Yes,
ulcerative, more,
uh,
more or
yes,
less,
ma'am. Yes, ma'am.
ulcerative mass. And you have to take punch biopsy is very easy, And the OPD procedure, you can just take it out. If it is a proliferative, like a small cabbage-like thing, hmm,
Yes, ma'am.
you can take out one punch and you can do the histopathological examination. But in your case, it's a big swelling, but the ulcers are small. It's not
Yes, ma'am.
proliferative, it is more ulcero-infiltrative.
Yes, ma'am.
So you have to take incidental biopsy here fits the
Incision
best.
error. Yes, ma'am.
You have to take some chunk of the healthy tissue and some chunk of the ulcerative part. Show you that
Yes,
you can
ma'am.
differentiate and the depth of invasions also that can be better appreciated. So you have taken a biopsy and sent it for
Histopathological examination, ma'am.
okay. When you're planning for a biopsy, what are the mandatory things you have to do?
Um, Ma'am, in the biopsy report, I have to mandatorily look for the histopathological type of the tumor and the grade. Along with that, I would also like to look if there is any lymphovascular space infiltration or any perineural
Okay, fine.
invasion.
Prior to that, I'm asking that what are the things you will do and then you will go for biopsy. You have
Um,
to do the viral markers first.
okay, yes, ma'am. Viral
Hmm.
markers.
If the patient is bleeding, then you have to do the BTCT and BTCT also you have to
Yes,
do
ma'am.
because it might go into bleeding. So after the viral markers are negative, if it is positive also, you can't discard the patients. You have to take extra precautions and do the biopsy. Fine. In
Okay.
the biopsy report, you have to see what type of malignancy it is, and you
Yes,
have
ma'am.
told that grade. You have to see the what you have to see. What else
Ma'am,
you can know from a small chunk of biopsy?
Ma'am, grade, the LVSI TNI status, and also I would like to look for the worst pattern of invasion 5 in head neck
In
patients,
the
ma'am.
small biopsy specimen, can you know all these things?
Um,
You can only
Ma'am,
know what type of malignancy it is, whether it is squamous or any lymphomatous things or in sarcomatous changes, features you are seeing. So mostly commonly it is squamous cell carcinoma.
yes,
Okay.
ma'am.
And you can know only grade.
Yes, ma'am.
The LBSA PNI are not much easier to know from the this type of small specimens.
Okay, ma'am.
So and for the node, what are you going to do? So I have told
Uh,
ultrasound guided FNC. Why? What is the size of your node?
Ma'am, 1.5 into 1.5 centimeter, ma'am.
1.5 to 1.5. That means 125 paisa size node. Huh?
Yes, ma'am.
Right? Hmm?
Yes, ma'am.
So can't you take it direct finish? You need ultrasound for that.
Ma'am, I told ultrasound guided because on inspection the node was not visible. It was only visible on palpation, and
Yeah, when the pathologists do, they palpate the node first, then they take the finishing. Not by only inspecting or looking to the node, they pierce it. You might have
ma'am,
done your path duty, pathology. Have you gone to pathology? How pathologists take the FNAC and all?
no, ma'am.
Okay. They first palpate the node and they fix it with their left hand palm, and they with two fingers they fix the node first, and then they take the finish from the right with the right hand. Okay.
Yes, ma'am.
Hmm. So
Ma'am,
without
ultrasound
taking the
does.
note, you can't take. Yeah, no, that simple direct FNAC also. You have to fix the note first, then you have to take the FNAC.
FNC. Okay, ma'am.
If it's not, if it is very small and not well appreciated, so why instead of blind FNAC, you can take it ultrasound guided FNAC. But 1.5, 1.5, okay, I think it is well, you can do direct FNAC. No guidance is required. Okay.
Okay, ma'am.
So your tell me the TNM staging.
Ma'am, this patient is clinically CT4 uh, N1M0, ma'am.
Hmm. Okay. So, what else you want to do in this case?
Ma'am, for this patient, I would like to go ahead with MRI of the head neck region
Mhm.
to assess the depth of invasion of the lesion. Along with that, since the patient is having trismus, I would also like to see if the lateral pterygoid muscles are involved so that I can stratify it as T4A or B more properly.
Okay. You go for CT, CCT of the face or MRI of the face? CMRI of the face.
Ma'am, MRI is preferred over CT in this case, ma'am.
Okay. Why?
Ma'am, it is mostly a soft tissue lesion.
Mm-hmm.
So the depth of invasion can be better assessed in MRI,
Mm-hmm.
and or the clinically the mandible or the alveolar sockets does not appear involved. So I don't suspect any bone erosion in this patient.
And in
So
MRI, you can well appreciate the perineural invasions also.
yes,
Any
ma'am.
not any vascular invasions, you can better appreciate with MRI. Okay.
Yes, ma'am.
So, what else you look for in radiology?
Um, Ma'am, in radiology, I'll also look for any lymph nodes in anywhere else, in any of the other cervical stations, or and in the imaging, I'll try to characterize whether it appears to be a metastatic node or a inflammatory node,
Mhm.
and I would also look for any space involvement, any masticated space, or any of the head neck spaces involvement to stage the patient.
So ENE you can also check for
Yes,
in the
ma'am.
MRI, which is
Yes, ma'am.
not that well appreciated in examination. You can jolly well know that from the imaging part.
Okay.
So your case is a lower T4A N1 M0. So
Yes,
how
ma'am.
can you write M0 in this? What
Ma'am,
metastasis? Which is the common site of metastasis?
ma'am, for patients of head neck carcinoma, common sites of metastasis are lung, liver, and bone. So, on clinical examination, I could not find any mm, clinical findings suggestive of metastasis, so I wrote it as M0, ma'am.
So you can write it MX, no? Clinical finding, if there is a lung med, what clinical finding do you have?
Ma'am, if it is a lung mets, the patient can have a cough because of the irritative symptoms, and any complaints of chest pain or any hemoptysis, ma'am.
Not always you get this cough and hemoptysis in long med patients. The med can be small and there may not be any cough and hemoptysis, but you have to always rule out the metastasis by simply chest X-ray or CCT
CT
thorax.
thorax, yes, ma'am.
HRCT thorax will also do. Okay.
Okay, ma'am.
How
Yes, ma'am.
common is liver met in these cases?
Um, Ma'am, since it's a locally advanced head neck cancer, liver mets can happen
But
at
it's
least.
always look for lung met and liver is uncommon, but it's better to separate to do and one ultrasound of the abdomen and pelvis.
Yes, ma'am.
Okay. So any role of any other thing you want to do?
Ma'am, apart from CT, thorax and abdomen, I can also do bone scan, ma'am. Or if
In
the
the case of
patient is,
squamous cell carcinoma, if it's not patient is not symptomatic, is it prudent to always go for bone scan?
ma'am, it's T4A with node involvement.
If patient is
Ma'am.
asymptomatic for bone, so there's no need to go for bone scan unlike breast cases. Okay.
Okay, ma'am.
So we have finished the biopsy part. We have finished the imaging part. Now what else?
Ma'am, I'd like to do the hematological investigations for this patient.
Mm-hmm.
Um, and I'd like to do a complete blood count to see if there is any, whether the hemoglobin, TLC count, or platelet counts are within normal limits. Or
Mm-hmm.
and I'll also like to do a liver function test, ma'am,
Okay.
and a kidney function test uh,
Mm-hmm.
for this patient.
Was the any information you get from this test apart from any basal anemic or thrombocytopenic? What biochemical test? What information extra it will give you?
Ma'am, by doing liver function test, I can assess the baseline hepatic function of the patient, and it will
Mm-hmm.
be easy to plan for any chemotherapeutic drugs in the course of the treatment, which can have hepatotoxicity.
Mm-hmm.
And for kidney function test also, I would like to know the baseline renal function of the patient before going ahead with any contrast based imaging. And also, if in the course of the treatment I'm planning to give any platinum chemotherapy or any nephrotoxic chemotherapeutic drugs, to know the baseline renal function, ma'am.
Okay. What information you have missed in liver function test?
Ma'am, any presence of any hepatic liver metastasis.
How you will know that from the blood test?
Ma'am, if
There isn't any
there is elevated liver enzymes,
which
or
any particular name for that?
ma'am, the SGPT, SGOT, ma'am,
No,
and
no,
the
no, not SGOT. Your alkaline phosphatase.
alkaline phosphatase is not. Also, it will also suggest if there is any associated bone mets for the
Yeah,
patient.
it will give indication for two metastasis. One is liver metastasis, other is bone metastasis. But the in bone metastasis, it is disproportionately high than the liver metastasis.
Okay, ma'am.
If you do, you have not suspected any liver or bone met, but the alkaline phosphatase is very much increased, like 5 times. It is 1500, like something. So you will suspect, is there any liver met? Is there any bone met? So you search accordingly for the metastatic sites, right?
Okay, yes, ma'am.
Okay. So with this diagnosis, how are going to manage it?
Ma'am,
What else you will do in investigations? You are talking about chemotherapy. So
yes, ma'am.
chemotherapy, which test is mandatory apart from the blood test for chemo to give?
Ma'am, I'll like to do a Pyoton odometry for this patient as well, ma'am.
Okay, because you may plan platinum compounds.
Yes, ma'am.
Okay, prior to that, any checkups, any
Uh,
cardiac checkup?
Cardiac checkup, baseline cardiac checkups also I'll do, ma'am. And along with that baseline, since I'll be irradiating the head neck region, I'll also like to get a baseline thyroid function test also, ma'am.
Fine. Baseline cardiac means what? You
Um,
just
b-
specifically tell that I will do root cardiac examination with 2D echo.
2D
You
echo,
need a
ma'am.
2D echo for that. Okay.
Okay,
So
ma'am.
You do that if the patient is not fit for chemotherapy, if there is any cardiac arrangements, not fit for chemotherapy, you can't give chemotherapy, no?
Yes, ma'am.
Okay. And if you're for this case, you are planning for what?
Ma'am, for this case, I'll be planning a definitive chemoradiotherapy, ma'am, with curative intent.
Okay. So for that, what you need? You need radiotherapy to be given. You need chemotherapy to be given. So tell me
Yes, ma'am.
about pre-radiotherapy checkups, which is mandatory. In head and neck, you already told that. Come again. Dental prophylaxis.
Yes, ma'am. Dental prophylaxis is
Okay.
PG12 or
Pre-radiotherapy dental checkups. You have told.
yes, dental prophylaxis. I
Yes, you have told. Huh? So dental prophylaxis means what?
ma'am, I'll look for any loose tooth or any cavious tooth that needs any extraction or any ill-fitted dentures are there or not, and whether the patient needs any dental procedure. If the
Mm-hmm.
patient needs any dental procedures to be done or any tooth extraction, I will
Mm-hmm.
advise to get it done prior to starting the radiotherapy,
Mm-hmm.
and allow for time for the wound healing before starting radiotherapy.
So, what is the minimum gap it is required for dental extraction to radiotherapy?
Ma'am, at least 3 weeks, minimum 3 weeks,
Two
ma'am.
to 3 weeks, you need the wound to be healed. Otherwise, what it will cause?
There will be delayed wound healing if I give radiotherapy, if I do dental extraction after radiotherapy, or if I don't give adequate time, ma'am.
No, after radiotherapy, dental extraction can't do.
Yes,
Before
ma'am.
radiotherapy, also, if you do dental extraction, there should be a minimum gap of 2 to 3 weeks. Otherwise, it will lead to your radiation necrosis. Wound
Yes,
healing
yes, ma'am.
won't be there, and there will be a radionecrosis of the jaw.
Jo-
Okay.
Yes, ma'am.
So baseline thyroid is done, and baseline audiometry you will do because you are planning for platinum compounds.
Yes, ma'am.
So tell me about chemoradiotherapy definitive.
Ma'am, for this,
What dose, what the technique, and what the site, and how you are giving, and what weekly chemotherapy or 3 weekly chemotherapy you are doing, and what the trial support this.
Ma'am, for this patient, I will like to give radiotherapy in conventional fractionation using 66 gray in 30 fractions to the gross disease and to the gross node, and along with that using IMRT technique. uh, Along with that, I'll also like to give 60 gray in 30 fractions to the CTV, and 54 gray in 30 fractions to the low dose elective lymph nodal region, and one single fraction in a day for 5 days in a week for 6 weeks. Along with that, weekly concurrent chemotherapy I will give prior to radiation, that is 40 mg per meter square of cisplatin. Um, and before each chemotherapy cycle, I'll also like to get a blood investigation of CBP and serum creatinine. And
Okay. Okay. What techniques you are going to use in this case?
for this case, I would like to use IMRT or a VMAT technique, ma'am.
Okay. And the dose you have told is it enough for the radical city part? You told 66 gray in 30 fractions.
66. Yes, ma'am.
66 gray, or you want to give more?
Ma'am, oral cavity.
It's a tongue,
Tongue.
no? Hmm.
Yes, ma'am.
Yeah.
66 oral.
You check it. Check the dose part.
Okay, ma'am.
Okay. You can give 70 gray in 33 fractions or in 35 fractions. And what technique you use to give, you tell high risk, intermediate risk, and low risk. You told, no? Those fractionation schedules.
Yes, ma'am. High risk will be the GTV with a 5 millimeter isotropic expansion and the gross nodes in the level 1A. The intermediate risk zone will be the CTV P2, which is 1 centimeter isotropic expansion of the GTV, cropped off from anatomical barriers. And along with that, bilateral level 1B, 2, 3, and 4A. And the low dose region will go to a dose of 54 gray in 30 fractions, which will be the lower neck, level 4B, 5, and level 7B, ma'am.
Okay. So, what you call it? When you give in all the same fractions, like 30 fractions, 70 gray,
Yes,
and
ma'am.
to high risk, and 59.8 to your intermediate, and 54 to the low risk group. What you call it? Is there any
Ma'am, it is,
terminology for that?
yes, ma'am. Ma'am, it is called simultaneous integrated boost technique using IMRT, ma'am.
Okay. What other techniques are also there? In MRT,
Ma'am,
one is SIB, other is you can go for sequential also, no?
sequential boost also I can give, ma'am. But with sequential boost, the overall treatment time will increase. So I
Okay.
would prefer a simultaneous integrated boost only, ma'am.
So the SIB is radiobiologically.
Superior, ma'am.
Okay. So everything I good, Sujay, have done good in the presentation part and discussion part. Only thing is you have to check your what is the tumor dose. Huh? It's not
Okay,
66 gray. It's higher than that, 70 gray. Okay. And
okay,
weekly
ma'am.
cisplatin, what dose you are giving going to give?
Ma'am, for weekly cisplatin, I'll go with 40 mg per meter square dose, ma'am.
Okay. Do you practice chemotherapy in your center while practicing radiotherapy, radiation oncology?
No, ma'am, only cisplatin, like this
Current
cervix and
one
head
you
neck
are
cases,
taking
ma'am.
care. Okay. So, what is the greatest complication you fear while giving cisplatin?
Ma'am, while giving cisplatin, there can be myelosuppression, ma'am. Along with that, patient cisplatin is a highly emetogenic drug, so patient can have nausea and vomiting. Also, cisplatin is also a ototoxic drug, so patient can have sensorineural hearing loss. Uh, these are the three most dreaded complications of cisplatin, ma'am.
Okay. What is I asked you was the rarest or greatest,
Oh,
but
okay,
yeah, you have told the commonest, but fine, it's fine. So, it can give rise to cardiac arrhythmia,
okay, ma'am.
the cisplatin, sometimes. So you have already done the cardiac checkups, but it can give to cardiac arrhythmias.
Okay, ma'am.
And what else cisplatin can give to?
Um, Ma'am, cisplatin is a cisplatin can also cause infertility as a side effect, ma'am, and
Is it?
it can also.
Fine, it's okay. Don't tell that infertility it will give to. Okay.
Okay, ma'am.
Uh, Electrolyte imbalance will be there, and you are taking
Oh, yes,
care
ma'am.
by giving your
Yes,
potassium and Maxal.
yes, ma'am.
What else you will look for while doing the your contouring part and dosimetry part? You have not told anything about OS. Tell me about OS in head and neck. In this case, in particular, oropharynx and
Uh,
oral cavity. Yeah.
Ma'am, for head neck OARs, I'll try to spare the spinal cord as much as possible. Along with that, the other OARs in that region are the parotids, bilateral parotid glands, ma'am, and the DARS structure, ma'am, dysphagia aspiration related structures, ma'am, and also the mandible, uh, and yes, ma'am, and the trachea, because we're irritating the neck also, so the
Mhm.
trachea and esophagus also, ma'am.
Okay. Have you heard of cochlea?
Yes, ma'am, cochlea also, we will try to spare, ma'am.
Because you are doing IMRT or VMAT, you have
Yes,
to
ma'am.
do that contouring part also. When but it's very important when you are doing nasopharynx.
Yes,
because
ma'am.
you are going very high up. Okay.
Yes, ma'am.
So, what is PRV?
Ma'am, PRV is a margin that we give to the normal structures, ma'am, to constrain the dose further. Mm,
You define PRV. What is ITV? This is your last question because we're
Ma'am,
almost done. The time is up. So just tell me what is ITV and what is PRV.
ma'am, ITV is the internal target. Sorry, ma'am. One minute. Ma'am, ITV is the internal target volume, which takes into account for the intrafraction movement of the target organ, and it was introduced by ICRU 83. Uh, Sorry, ICRU 62, and it takes into account the intrafraction movement of the organs, and it is defined as CTV plus uh, internal margin. CTV plus internal margin is gives the ITV volume, ma'am.
Okay. So in between the CTV and PTV, it is divided into two. One for the internal organ motion, one for the setup error margins, setup margins. Okay. So
Yes,
for
ma'am.
likewise your target GTB, CTB, it moves with respiration. Likewise the OARs also can move. The internal motions can be occurred, like blood vessel movement and all, internal
Yes, ma'am.
motions. So for that reason, you are giving PRB, one 3 margin to the cord and brain stem and all. So within that volume, the OARs can move because of the blood flows and their internal motion. Okay.
Yes, ma'am.
So, Srijay, you have overall done well, but in some parts, I think you need some improvement, but you have done well. So, Dr. Ajitesh, thank you for that. Dr. Ajitesh?
Yes, and thank you, ma'am, for
Huh.
moderating the sessions. You have spared your valuable time for this webinar. Thank you. Prior to closing this session one, Dr. Sujali,
Yes,
are you
sir.
there?
Yes, sir.
Yes, and to all the residents, it is a takeaway that while you are describing the contouring guidelines, you need to say when you are describing the contouring, like that for the hair and neck, like CTV, GTV, you should mention the guidelines that you are following. Like say in this case, you are following the Dahanka 2020 guidelines, no?
Yes, sir.
So you have to mention that.
Okay, sir.
Okay.
Sir, I
And
have a question.
yeah,
I actually had posted also, but it went off. So, like
sorry.
in head and neck case,
Yeah,
when we have neck nodes positive, like do we
yeah.
mention that in the like generalized lymphadenopathy also?
Ma'am,
That
Yeah.
means,
will
yeah, I have read your question. You have asked whether if there is any lymph node already visible or already palpable lymph node in the patient, whether you will describe in systemic lymph nodopathy or it will go to the proper examination proper of the regional. That's the question, no?
yes, I think so.
Is that the question?
Yes, ma'am.
Yes, ma'am.
Whether you will describe that lymph node in the regional part or in the systemic part?
Yes, ma'am.
Yes,
Okay.
ma'am.
So when there is already a lymph node, better you tell that in the regional examination that there is a neck node and you have to describe it fully, and you can tell that there is no other lymphadenopathy elsewhere. When you are examining a case of lymphoma, then you have to tell the lymph nodes of all sides with very much emphasis into the regions like inguinal nodes, the axillary lymph nodes, everything you have to give much emphasis on that. But in this case, in head and neck case, you can tell that there is elsewhere there is no other lymphadenopathy and there is a lymph node on the neck node region. And when you go to the examination proper in the regional site, like head and neck, you describe the lymph node fully.
Okay, ma'am. Thank you.
Okay.
Ma'am, I have one question.
Yeah.
Ma'am, how do we quantify smokeless tobacco as in quid and all?
Smokeless tobacco, you can't tell packs per year, no? So you can tell that how many pans, we call it pans and you tell it quid, no? How many per day you can tell that? Ajitesh, what is
Yes.
your take on this?
Hello, am I audible?
Quantify the, you're audible. Quantify the smokeless tobacco, like
So
pan, gutka.
in this case, if the patient is telling that he's having pan or gutka like that, so we can just mention that whether the patient is taking this many quantities of pan or gutka per day, and that will be, I think that will be fine.
Numbers of
Yeah, yeah.
pans and
Yes,
gutkas.
ma'am. Yes, ma'am.
So I think we are done. So now I think Ajitesh has to take.
Madam, I
Hello.
have a doubt, ma'am. Suppose uh, there are two lesions as described in this case on inspection, but on palpation, there is induration which continues throughout the tongue tissue. So we take as two separate lesions or as a single lesion staged in this case, ma'am.
No, see, in this case, the whole tongue is indurated, but it is ulcerated in two areas. Okay.
Hmm.
So you have
So
to tell is it a whole, not a left sided, not right sided.
as a whole, we
Hereditary,
have to
whole tongue. The full tongue is involved with the two ulcers.
even
One
with
left.
the gap, superficial gap
No,
of normal tissue.
that can,
Hmm.
no. The palpatory finding is the final finding, not the inspection finding. Only you have to confirm your inspection findings by palpation without putting your finger onto the mouth. What you have seen, you have to confirm that. But you have seen two ulcers, but not necessarily that you have palpated as two ulcers. It is one tongue that is fully indurated. It's a size of 7 centimeter and 5 into 4 centimeter likewise, and there are ulcerations over there.
Okay, ma'am. Thank you, ma'am. Thank you so
Thank
much.
you so much.
Ma'am, also, okay.
Hello, ma'am. Hello.
Sir, you can also tell it.
Yeah. Please go ahead.
So, like, once in my FAT examination, like when we tell the dose as like SIB component, like 66 in 30 maybe, where in some fractions we give 2.2.
Yeah.
So I was advised like not to answer it as like with concurrent chemo, as she did today.
Usually, in case of when we are going for hypofractionation like those things, we don't use concurrent chemo. But in these cases, we can go ahead with concurrent chemo, I think. Okay. Along with SIB, you can go ahead with concurrent chemo in head and neck malignancy mostly. Okay.
Okay, sir. Thank you.
Is there any role of bimanual palpation during the examination, sir and ma'am?
Yes, there is a role of bimanual palpation in case of oral malignancy, in case of head and neck malignancy, in case of buccal mucosa. Yes, there is a role of you have to insert your index finger within the oral cavity, and you can palpate the lesion within with the help of your both the fingers. Okay.
Okay, sir. Thank you, sir.
Okay. Are there any questions? So can we go ahead with the second session?
Jitesh?
Yes, ma'am.
Yeah, I'm just winding up. Thanks for invitation. Thanks, Kanu, and thanks, Ajitesh.
And thank you, ma'am, for sparing your valuable time and
It's always a pleasure and honor for the invitation. Thank you so
okay,
much.
thank
Thank you,
you.
students. Bye bye.
So after the first session, we'll be moving ahead with the second session, which will be an OSCE in palliative oncology and biostatistics. Dr. Ankita Lahiri,
Yes, sir.
who is resident from Apollo Multispecialty Hospital, Kolkata.
Yes.
She will be answering the questions. Okay. Are you online?
Yes, sir. Yes.
Okay. So let me share the slides. Are the slides visible?
Yes, sir.
Okay. So as we have been doing in the last 2 days, so this session will be the OSCE for the biostatistics and palliative care. We appreciate all your answers in the chat box and also the questions.